welcome back, listeners. We're so glad that you're here. Thank you to those of you who have subscribed and to our sponsor, Castle Biosciences. Today, I'm joined by Dr. Chymlowski, and he is a uveal melanoma medical oncologist at UCLA in the West Coast, and he's actually here to chat with us about the only FDA-approved liver-directed therapy for metastatic uveal melanoma. Dr. Chymlowski, thank you so much for being here. So can you just tell me how exciting this therapy is for you guys at UCLA?
Definitely. It's a pleasure to be here and talk to patients and family members of people who suffer with uveal melanoma. So, Hepzato, or isolated perfusion with melphalan of the liver, was approved by FDA a few months ago. Although we were not part of the clinical trials that led to the approval of this therapy, as soon as the therapy was approved, we put a lot of effort so that this method of treatment of liver metastasis of uveal melanoma can be available to our patients. We've been actively treating patients for the last 3 months. I think we were the first site that were using commercial product on the West Coast.
Okay, this is so exciting, and I want to get more into this, but can you just give us a little bit more background as to how you got into uveal melanoma as part of your profession as an oncologist?
It was interesting. I've been doing it for about 19 years right now. So I'm a professor of medicine here at University of California, Los Angeles. Initially, I did my PhD in immunology. So when I was doing my fellowship in oncology, I was looking for areas where immunology or immunotherapy could be applied. And of course, melanoma was a leader in the field. Since I work here at UCLA, and we have a very active uveal melanoma center here with our Stein Eye Institute, and Dr. Tara McConnell, who is our ophthalmologic oncologist and who specializes in treatment of uveal melanoma in the eye, a local treatment of uveal melanoma. We formed this group. Then she serves, as a primary ophthalmologist for these patients, and I serve as a primary oncologist here at UCLA. So initially, it came just because of excitement and interest in the treatment of patients with advanced melanoma. Uveal melanoma is, of course, a critical part of this. It's a very different disease from cutaneous melanoma. This allows us to develop clinical research in this patient population, create quite a large patient population. I think I'm following about 150 patients with uveal melanoma right now. We try to participate in all the most important clinical trials in uveal melanoma. We are part of advisory groups and that lead to the development of new treatments. And for many years we've been saying when we have very few exciting therapies, slowly but surely we are coming up with new treatments, like even this kit which was being developed for many years. I would say at least 15 years probably, if not longer, for the patients, and finally it's available for our patients.
So you mentioned earlier that you guys did not participate in the clinical trial for Hepzato kit. So how did the process come about for you guys to commercialize and just get this ready to go as soon as possible after FDA approval?
I can give you a little bit of historic background to some degree. Very early when the company was starting, the initial development, when no one heard probably about the company very much, we had some efforts, to open the trial, but for mainly administrative reasons, this did not come to fruition, so we kind of put it on hold. I've been following the development of the procedure and always interested in following the data available. As we knew that FDA is reviewing the data, here's our uveal melanoma group. We talked and we discussed the importance of bringing this procedure to UCLA. I have to say, since it's a liver-directed procedure and communication between us medical oncologists, or me a medical oncologist, and our interventional radiologists was extremely important. We are very fortunate here when we have maybe somewhat a small team, but this I kind of consider it advantage because we communicate directly with each other, so we very often can overcome any possible hurdles between ophthalmologists, medical oncologists, and interventional radiologists. So I have to mention Dr. Sid Padia, who is our lead in interventional radiology for patients with uveal melanoma. For many years, we've been using together radiofrequency ablation or radioembolization with radioactive ether spheres as a methods, a localized treatments to the liver for patients with uveal melanoma. So we have a very close relationship, and this was very easy to start the interest of Dr. Padilla in this new procedure, isolated perfusion with melphalan of the liver procedure. So we already knew we were waiting, and as soon as it was approved, we started discussions with the company, because like with any procedure, nothing like that was ever approved available to patients, not saying uveal melanoma, but any other patients, any other cancers. So this obviously requires quite an extensive training of people who are involved, and I know that you intend to invite Dr. Padilla for another talk here, so I'm sure he will talk about this even more. But we spend a lot of time on training not only the physicians who perform the procedure, as medical oncologists, to understand the process, how to advise the patients and educate them on benefits and possible complications of the procedures, but also all the staff who are involved in the treatment of these patients. These patients go to the hospital. They are usually hospitalized for about 24 hours. And it's not only the physician who performs the procedure. You need to have the nurses who help. We need these patients on anticoagulation with heparin. So we have to have people who know how to handle anticoagulation. They require anesthesia, so anesthesiologists are involved. They require also a perfusion of the blood on the machine, so our special perfusionist is involved. And then after the procedure is done, they go for monitoring either to intensive care unit, although recently we've started monitoring after discharge from the interventional radiology suite on our regular oncology floor. So we had to provide the training for our nurses, the management, and the staff, so everybody's prepared for this for the patients. This did require, I would say 3 to 4 months of preparations and intensive work, multiple meetings. But I think this gave us this confidence when we can provide this therapy, and also because we believe in the procedure, we believe when we can help the patients, we can control the disease better. It gave us this energy to overcome any possible hurdles institutions may have. It's always there is always a desire among treating physicians to bring new procedures, and when you have to face administrative limitations, just because it's something new, no one knows what to do. Everybody wants to have something new, but it has to be done safe for the patients. And so this was a little bit of excitement, hard work, but the procedure is available.
That's incredible. So you mentioned that you guys spent about 3 to 6 months preparing to have this procedure available, and it sounds like you have this well-running kind of machine that knows what to do now. So when was the first time you guys performed the head kit procedure for a patient?
So actually we've performed the first time the procedure in early April. This was, I think, the first week of April. I forget the exact date. This was associated also that I think on April the 1st, finally Medicare had a financial code for the procedure, which of course, reimbursement and payment for the procedure is extremely important. As a part also, it has to be also kind of ironed out before we do the procedure. So that's why we were ready with the staff and training and all of this already in January probably, but we still waited for just the final steps.
So on average, now that you guys have this kind of well-oiled machine, you've got everything down to a science for how you're going to perform the procedure as a hospital staff. How often do you perform this procedure for patients with uveal melanoma?
So I think so far in the last 3 months we treated 6 patients. Uveal melanoma is not the most common disease, not the most common cancer. When we select the patients, we have to have an appropriate candidate, for a breakthrough procedure, but it is a liver-directed therapy. So it means if a patient has, for example, extensive disease outside of the liver, then this will not be treated. So it has to be clear, because very often our patients say, "Oh, I have lung metastasis. Can you do the same on my lung?" or things like that. So no, unfortunately not. Uveal melanoma was selected for this procedure because many patients have just metastasis in the liver, so they are possibly good candidates. As we select this, it's also important to remember that these patients have to be in a good shape. If a disease makes them very, very sick, they are unlikely to benefit from the procedure. But also, since we are delivering chemotherapy into the liver, exposing metastasis to a very high dose of chemotherapy, and this is later on filtered out, if the liver function is very poor, then there is a risk when we can actually make the patient worse rather than better. So the patient selection is also important. And it's also important for physicians who might see these patients with uveal melanoma. When if I hear about this new procedure, this could be offered for my patient, you want to think about it early in the course of the disease, because if the patient's conditions worsen or the function of the liver worsens, they might lose the chance to benefit from this procedure. So that's why I think 6 patients. The treatment on average is 1 treatment. We will repeat the scans, follow the patients to see if they tolerate it okay, if they had any benefit, but on average we plan for treatments every 2 months, every 8 weeks, 2 months or 8 weeks. So we had patients who already have undergone 2 procedures and they've tolerated well, and as the new patients come, we start offering more and more procedures.
So let's just walk briefly through kind of some of the follow-up process. You kind of alluded a little to this. After they've had this 24-hour monitoring in the hospital, the procedure's been done, what should a patient expect from a follow-up care visit with someone like you?
It's important to know why we monitor this patient. It's not only, we also monitor because, as I mentioned, we use blood thinners, and interventional radiologist has to get with the special catheters to the blood vessels so they can, deliver therapy to the liver. So actually the catheters go through 3 different sites, 3 different blood vessels. So we monitor to be sure that there's no bleeding in the site, and then a few days after discharge, I do come and follow up with the patient to assess the surgical site to be sure that they don't have bruises or bleeding or any sites of infection. So far we haven't had any significant problems. And also because we are using chemotherapy, this chemotherapy is delivered to the liver and later on filtered out, but a small percentage of this chemotherapy kind of leaks out to the system, so can cause systemic side effects of chemotherapy, and mainly a decrease in white blood cell count and a decrease in the platelet count. So about a week after the procedure, we see patients to monitor also the white blood cell count and platelet count, to hemoglobin level, to be sure that they did not lose. We have right now medications that can boost white blood cell count in case it is too low, because if the white blood cell count goes too low, then the patients are at increased risk for infection. Luckily, it's a temporary decrease, and then the white blood cell count recovers. But because of that, I usually see them about a week later and the next 2 weeks later. And just to be sure, when they don't have any additional nausea or pain, if they had after the procedure. Also, patients, of course, have a contact number with us to get in touch with us in case they develop any symptoms in between the visits. And as we go on, we decide, with our interventional radiology here with Dr. Padia, when to plan on the next procedure.
You mentioned a little bit of the patient tolerance over time of the treatment, but it sounds like for the most part, as long as they're a good candidate, the patients you're seeing are tolerating this well.
They've been tolerating it okay. We have to anticipate, we don't see it very much. If they undergo several procedures, this blood work abnormalities that I mentioned might be a little bit more pronounced, because there will be a little bit of cumulative effect, but so far it's been okay.
And so just for everybody's information, what would be the maximum number of Hepzato kit treatments that a patient could have if they were spread out?
There is no limit. Realistically, probably will be about 6 treatments. So because of course, if you're very weak, we continue the treatment for as long as it helps the patient, and so means when we do periodic imaging of the liver, we still see the benefit in control of the disease, and as long as the patient tolerates. And we'll see how it goes in our clinical practice. We probably want at some point, even if the patients have a good tolerance, to give a good vacation of the treatment. Patients will do several treatments and will do the break to monitor the patient to see if they really need more treatments.
This is a very novel kind of way for us to be able to approach liver-directed therapy. So I wanted to ask you about what are some of the unique advantages that you have as a medical oncologist treating uveal melanoma metastatic patients. What are the unique advantages to having an FDA-approved liver-directed treatment to work with?
We participate in multiple clinical trials, so if we have any procedures or any treatments being developed as a part of a clinical trials, it's exciting because we can offer new therapy, but there are also limitations associated with it because we have to follow the protocol which was provided, and we can not deviate from the protocol. The protocols are created for a reason. So very often it frustrates the patients because some small blood work abnormalities or other comorbid conditions they may have may exclude patients from access to the clinical trials or the treatments on the clinical trials. Once the procedure is approved, we have a little bit more flexibility. As I mentioned before, we have to be sure when we can offer this procedure safely. So when we select patients for the treatment, we have to know that these patients will be able to tolerate, and then we are not going to worsen the condition with the procedure. But it gives us more flexibility if a patient has some comorbid conditions that otherwise would exclude them from participation in the clinical trials. Also, probably more important, we know right now that this is a liver-directed therapy, but we know that cancer is usually a systemic disease, travel through the bloodstream, and although we may see it only in the liver, which very often it is in other parts of the body. So we, as I mentioned before, we had patients who had lesions in the liver and maybe the bone, or in the liver and in the lungs. This procedure would address only the liver. Or we have patients who previously started systemic therapy for the liver, and now we have a procedure available and we are adding this procedure to systemic therapy. So in development of the kit, no other treatments were offered. Right now, since we use a lot of immunotherapy, namely most commonly we prescribe nivolumab and ipilimumab combination, or if the patient is HLA-A2.1 positive, as a standard systemic therapies that provide active against uveal melanoma and can improve disease control. What we started doing here at UCLA, we are actually combining this systemic therapy together with Hepzato. It means it requires a little bit of planning. Patient may start with immunotherapy. When we schedule the procedure, they go the procedure. Then when we see when they recovered, and then they have 2 months of break between procedures, so they continue their systemic therapy in between. Hopefully this allows us to it is a little bit a more aggressive approach, but hopefully with a more aggressive approach we can even achieve a better control of the disease.
Well, and I think that's such an important thing, to be able to use that creativity that you guys have. I know most of you guys are the uveal melanoma medical oncology field. This is such a niche area. It's such a small community of doctors, and I can only imagine the excitement that your colleagues have about being able to do combination therapy with multiple different FDA-approved options. And just to see, in what ways can we make these work together to benefit the patient. So I love that. Is there anything that you want to share just as we end about Hepzato Kit for any patients, any listeners, any other doctors maybe considering this therapy in the center where they work?
I think it's an exciting form of treatment. I do point out that it does require training. And it's not a training only of physicians who perform procedure, but also the staff surrounding and preparation. So it may take up to 3 months of preparation. And I would encourage, the company provides they have resources, they provide good training for people, and they help. Some of the physicians and centers approach us for advice. So say, hey, can you share your experience, how you did it, so we can have it available. This would be exciting because the patients hopefully don't have to travel so far, to get the procedure, although we do have patients who travel from other states to ask for possible procedures. It's important to select the patients appropriately, but we are here to help also with any advice or to share the experience if people have questions.
Well, Dr. Chemlowski, I'm so grateful that you were able to come on as a guest. We're so thankful for your expertise, and we look forward to being able to chat with your colleague, Dr. Padia, as well in the future. So thank you so much for joining us, guys, and we will see you next time.
Thank you.